Good morning, everyone. Good afternoon to some of you. Thank you for joining us today. We're going to go ahead and get started. We're expecting that we'll have a few more participants join us in the next few minutes, so I'm going to start slow, and then we will ramp up into the more interesting bits when we get to our speakers. So I'll start by telling you a little bit about YouthPower Learning. Thank you for coming to our webinar. YouthPower Learning advances solutions through integrated research and development programs to improve the capacity of youth-led and youth-serving institutions. We have a strong focus on positive youth development, which recognizes young people's inherent rights and results in youth who have assets, the ability to leverage those assets, their agency, and the ability to contribute to positive change for themselves and their communities. This is, of course, entirely dependent on them being surrounded by an enabling environment that supports them to do these things. In particular today, we're here to support USAID's efforts to promote youth engagement and holistic positive youth development programming globally. This webinar through this webinar, we are supporting USAID and PEPFAR's efforts to reach their 95-95-95 goals with research and programmatic considerations for adolescent girls and young women in the context of HIV index testing and partner notification rolled out in a way that minimizes social harm. And that was a lot of jargon very quickly, and I do apologize for that, but fortunately you are signed up to listen to us explain all of it to you now. So I'll do a quick rundown of today's speakers. We're going to start with a presentation from Anne Stengel. Anne is a senior behavioral scientist at the International Center for Research on Women. She has 17 years of international public health experience in Africa, Asia, and the Caribbean with a focus on stigma, qualitative and quantitative research methods, research design, statistical analysis, systematic reviews, and monitoring and evaluation. Her research centers on human rights and stigma, particularly as they relate to HIV prevention, care, and treatment, key populations, healthy transitions to adulthood for adolescents, health-related quality of life, and equitable access to health care. Then you're going to hear a little bit from me, and I apologize for not introducing myself earlier. My name is Chelsea Ricker. I am the co-champion of the Gender and Positive Youth Development Community of Practice for YouthPower Learning, and I'm an independent consultant with expertise in adolescent sexual and reproductive health and rights and access to youth-friendly health services. After you get a bit of an informational download from Anne and myself, we're going to have a bit of a discussion, and for that we'll be welcoming Amelia Peltz, Senior Gender Advisor from USAID. Amelia is within the Gender and Sexual Diversity Branch in the Office of HIV/AIDS at USAID. She has over 18 years of experience designing, implementing, monitoring, and evaluating development and humanitarian assistance programs that promote gender equality and empower women and girls. And last but certainly not least, we'll be joined by Jacqueline Alisi. Jackie has been so kind with her time with joining us both for this webinar and in helping us develop these tools. Jackie is a self-driven, committed young woman openly living with HIV. She's passionate about working with young people living with HIV. She has done so extensively in various capacities, including as Executive Director of the Uganda Network of Young People Living with HIV and AIDS, and as the only young person to chair the Policy Advocacy and Programs Committee for the National Forum of People Living with HIV/AIDS Networks in Uganda. She's also a board member of the Global Network of People Living with HIV and the Athena Network. To cap off all of that, Jackie has also conceptualized, pioneered, and organized the first Y+ beauty pageant in Uganda for young people living with HIV, which focuses on reducing HIV-related stigma at all levels, and has been a huge success in its first 2 years. So I want to thank Jackie for joining us. I also want to take a quick moment to thank Dr. Atuk William of the International Youth Alliance for Family Planning, and Ndege Munyabaranga of the African Young Positives Network and Kigali Hope Association, who also provided substantial input and advice into the tools that you'll be hearing about today. So thank you very much to all of our speakers and our contributors. And I will get into a little I'll go over, I'm going to stop talking soon, I absolutely promise you. So like I said, first you'll hear a little bit from Anne and myself about the research and the tools that we're discussing today. And then we will have a panel discussion with Amelia, Jackie, and Anne. And then we'll have a quick Q&A. So at any point during the presentations, if you have a question, please enter it into the chat box. We will be collecting those over the entire session and making sure that we get them to the right panelists. Anything that we can't get to during the Q&A itself, we will respond to in writing after the webinar, which we will also make the recording of this webinar available on the YouthPower website later this week, most likely. So with no further ado, I'm going to turn over to Anne.
Good morning, everyone, and good afternoon. It's a pleasure to be here with you today. On today's webinar, we will be sharing technical and programmatic considerations for conducting HIV index testing and partner notification with adolescent girls and young women based on our review of the literature. This will include what we learned about potential social harms for adolescent girls and young women and recommendations for mitigating such harm. We will also discuss specific tools we developed to assist providers to deliver HIV index testing and partner notification services with adolescent girls and young women. So what does the evidence tell us about HIV index testing and partner notification among adolescent girls and young women? Unfortunately, very little. We were only able to identify one study that examined the acceptability of partner notification following sexually transmitted infection testing among adolescents in the US. We did not identify any studies that explored the feasibility and acceptability of partner notification following HIV testing, so it's really unclear whether this testing strategy will be feasible and acceptable with adolescent girls and young women. We did learn that adolescents face specific challenges that will likely influence the rollout of index testing and partner notification services. For example, in healthcare settings, unequal power dynamics in the provider-adolescent client relationship, as well as judgmental attitudes about sexual activity among adolescents that providers often hold, make the risk of coercion to notify partners real. In addition, youth often lack access to age-appropriate services because few providers are trained to provide adolescent-friendly sexual and reproductive health services. Another challenge is that taboos around discussing sex openly in many contexts may deter people from consenting to partner notification services, particularly adolescents. The risk of violence is also a big concern. Adolescent girls and young women are more vulnerable to experiencing violence than adult women. This heightened risk may have a greater impact on adolescent girls and young women in the context of partner notification services. For example, more than 1 in 4 girls' first sexual experience under the age of 18 is unwanted. And we know that the most common perpetrators of violence against girls are their current or former partners, boyfriends, or husbands. Lastly, fear of experiencing stigma as a result of their HIV status may be more of an issue for adolescent girls who have fewer resources and sources of support than adult women to cope with stigma and discrimination experienced. So what do studies with adult women tell us? So we identified 18 studies that reported data on either the barriers to or challenges associated with HIV partner notification or the relationship between HIV index testing and social harms, such as intimate partner violence or stigma. 17 of these studies were conducted among adult women and men, and these studies spanned Africa, North America, and Latin America from 1999 to 2018. So the evidence suggests that anticipating social harms like violence and stigma did not deter women from notifying their partners of their HIV status. In addition, very few cases of notification-related violence were reported. However, at least one study specifically excluded violent partners of women from the study. Several barriers to partner notification were identified among adult women. These included fear of partnership dissolution, fear of being abandoned, difficulty notifying a partner when sex work was her main livelihood, and power differentials in relationships that place women at a disadvantage and make them hesitant to inform their partners about their HIV positive status. So in terms of research recommendations, Prior to implementing HIV index testing and partner notification with adolescent girls and young women, countries should ideally conduct feasibility and acceptability studies and situational analyses to determine what methods of partner notification are most appropriate in their context. During implementation of HIV index testing and partner notification for adolescent girls and young women, it will be important to conduct operations research to assess the availability, accessibility, acceptability, and quality of the services being provided, and course-correct methodologies and approaches, or introduce training programs for providers as needed. So now I'll review some program recommendations for index testing and partner notification with adolescent girls and young women. These recommendations fall under 4 main areas: general considerations, monitoring, training needs, and resources for adolescents living with HIV and survivors of intimate partner violence. So there are a number of considerations that should be taken into account around partner notification for adolescent girls and young women. Firstly, it's critical for countries to develop or clarify consent policies and practices to facilitate access to and uptake of HIV testing services for adolescents. The inability of minors in most countries to seek HIV testing without parental consent is a potential barrier to scaling up HIV partner notification services with adolescent girls and young women. According to UNAIDS, parental consent is required for young people under certain ages before accessing one or more SRH services in 72 countries. Given the varied consent policies in place for adolescents and young people aged 10 to 24 in low and middle income countries, implementing HIV partner notification with adolescent girls and young women in that age group may prove challenging. Secondly, it will be important to implement community mobilization strategies to increase general awareness of the 95-95-95 targets and generate enthusiasm for HIV testing services, including index testing and partner notification. This should help to minimize stigma towards adolescent girls and young women, as they will be less likely to be seen as the target of HIV index testing and partner notification. And lastly, efforts should be made to expand HIV index testing and partner notification for adolescent boys and young men alongside adolescent girls and young women. Similar to the community mobilization efforts I just mentioned, this will help to reduce the likelihood that adolescent girls and young women are seen as vectors of disease and stigmatized for bringing HIV infection into relationships, similar to what happened initially with HIV testing of women at ANC clinics. So routine program monitoring of HIV partner notification services for adolescent girls and young women will be critical to identify and correct any procedures or processes that may facilitate social harms. This could include following up with adolescent girls and young women a few weeks or months after index testing and partner notification to see whether they encountered any social harms linked with the services and what social support services they have accessed or are in need of. Monitoring could also include exit interviews with young female clients and observations of provider-client interactions and counseling sessions by trained healthcare administrators. Such observations would generate feedback to providers on their service delivery approach and ensure that voluntarism with informed consent and the right to decline is being adhered to. Lastly, brief provider surveys could be implemented every 6 to 12 months or so to seek anonymous feedback from providers on the new services as they are rolled out for adolescent girls and young women. Excuse me. Training and support for providers is also needed and will be critical to successful scale-up of HIV index testing and partner notification. Specifically, providers should receive training on how to provide adolescent-friendly HIV, sexual and reproductive health, and sexual and gender-based violence services, how to conduct routine inquiry for IPV with adolescent girls and young women in alignment with WHO guidelines, and lastly, how to provide stigma-free and gender-sensitive services in a non-judgmental and supportive manner. Lastly, countries should ensure that resources like GBV support services and social support services for adults and adolescents living with HIV are in place and prepared to support all adolescents referred following HIV index testing and partner notification. These support services should be integrated into HIV and healthcare services where feasible to facilitate access and use by adolescent girls and young women. For example, GBV resource centers and support groups for adolescents living with HIV would enable adolescents to cope with IPV, stigma, mental health issues, concerns around disclosure, coming to terms with their HIV status, and staying engaged in HIV care and treatment. In terms of key takeaways from our review, ensuring voluntarism with informed consent and the explicit right to decline is really paramount. This will go a long way towards protecting adolescent girls and young women from potential social harms linked with partner notification services. As with adults, partner notification services for adolescent girls and young women should always be voluntary. Offering partner notification services and specific partner notification methods in a way that allows for choice and opting out if adolescent girls and young women fear adverse consequences of partner notification should be an underlying principle in the implementation of HIV index testing and partner notification services for adolescent girls and young women. Methods of partner notification that are anonymous, such as provider referral, should be prioritized to ensure confidentiality and avoid adverse outcomes. Providers should be trained to conduct routine inquiry for IPV with adolescent girls and young women and be able to provide first-line support as needed. And lastly, developing and integrating support services for adolescent girls and young women living with HIV and adolescent survivors of violence is critical. These services should be implemented alongside HIV index testing and partner notification so that active referral to these services becomes a routine part of this HIV testing method for adolescent girls and young women. So I'll now turn you over to Chelsea, and she's going to walk you through the tools and job aids that we developed for providers. Thanks very much.
Great. Thanks, everyone. So as we were developing the tools for providers and the job aid for providers for rolling out index testing and partner notification services, there are a few things that we wanted to specifically consider for the adolescent girl and young woman audience. One, and you will see this as we go further on, is the incredible overlap and need for integration between HIV index testing and intimate partner violence and violence screening. As we know, for as many as 1 in 4 adolescent women, first sexual experience is unwanted, forced, or coerced. And women of all ages, but in particular adolescent girls who have experienced intimate partner violence and sexual violence are more vulnerable to HIV. So we also wanted to consider some of the particular vulnerabilities that adolescent girls and young women face around HIV outside of intimate partner violence. We know that adolescent girls they have a significantly higher risk for HIV infection than their male peers or older women, and yet they have much less access to HIV testing or treatment. Part of that we know is because they are frequently disempowered or have less decision-making power relative to their male peers or older family members, including in their decision-making when it comes to sexual activity or accessing reproductive health or family planning services or the HIV testing. We know that adolescent girls and young women face stigma, discrimination, punishment, or violence from their families, not only for disclosing their HIV status, but also just for the mere fact of their sexual activity. And so there's an additional risk for adolescent girls and young women in disclosing HIV status around also disclosing that they are sexually active. And that adolescent girls and young women may face a higher risk of intimate partner or other violence if their HIV status is known, and that fear of intimate partner or family violence if their HIV status is known may be more operational for adolescent girls and young women than it is for older women who have more access to resources or empowerment within their family or social structures. And we also know, sorry, this is a very negative slide and I apologize for opening with it, but we also know that despite investments in youth-friendly health services over the past decade, too many adolescent girls and young women still lack access to trained providers and to youth-friendly health services. So while index testing offers this incredibly crucial opportunity to identify and link HIV-positive adolescent girls and young women and their partners to treatment and care, it has to be rolled out in a way that acknowledges the increased risks for this age group and the needs of providers and testing centers to integrate testing with other sexual and reproductive health and sexual and gender-based violence services. So what we've created is a tool not only for providers but also for health program implementers to take into consideration some of these sociocultural and programmatic factors and then incorporate them into their decision-making structure as they go through services. So we really wanted to highlight in the considerations for adolescent girls and young women clients that adolescents have the same rights as adult clients to decide if, when, and how to disclose their HIV status. This is non-negotiable for, I'm sure, many of the people on the line and for many of the organizations that we work with, and we wanted to put that right up front. We also wanted to put right up front that providers have a responsibility to maintain the confidentiality of their adolescent clients' HIV status, including from parents or guardians and sexual partners, but we also wanted to acknowledge that in some legal and policy contexts that may not be possible, and in those cases providers have a responsibility to be upfront with their adolescent clients about what their disclosure requirements are. We also focused on the heterogeneity of adolescent populations. All adolescents are not the same. All adolescent girls and young women are not the same. They have different levels of capacity, different levels of experience, and they have different vulnerabilities. And so we wanted to acknowledge the need to take into account other factors such as gender, sexual orientation, economic status, religious or ethnic minority, migrant or refugee status, marital status, and more, as well as the level of individual development and the need to assess adolescents' ability to understand and overcome their own risks, and to put up front, again, that it's the provider's responsibility to support the adolescent client in understanding and making informed decisions about index testing and HIV partner notification. Hang on, sorry, I have a lot of notes here. So from a programmatic level, what that means is, once again, we're putting up front these issues of choice and consent, and highlighting that all clients, and in particular adolescent girls and young women, have the right to opt out of HIV partner notification and index testing services at any time and for any reason. These are voluntary services and they need to be upheld in that way. And we also wanted to highlight again that providers should have resources available that explain HIV and HIV disclosure in youth-friendly and accessible language. We also needed to highlight that many countries have different legal ages of consent for sexual activity and for access to services, and that where an adolescent is in regard to those different legal ages of consent is important to understand and to factor into your decision-making matrix. So in the sample form that you can see, we've actually incorporated a checkbox to note for the provider to note when they record the client's age, whether that client is above the legal age of consent to sex, and then a decision-making point highlighting that if they're not above the legal age of consent to sex, that these services are most likely not recommended for that client. Hang on. So, in addition to the programmatic and service delivery considerations, sorry. Can we go back a slide, actually? So we've also integrated in a routine inquiry for intimate partner violence as you're recording partner information, and an overall safety check for adolescents to check for violence in the home or in the environment that may make HIV disclosure and partner notification ill-advised or risky. We've also added in referral and follow-up services and prompts for providers to the forms to know where those referrals should go and where they should be integrated with other youth-friendly services. We also want to acknowledge that most likely index testing and partner notification services and routine inquiry for intimate partner violence will not be recommended in an environment where there's no follow-up service available, if there are no youth-friendly health services, if there are no SGDV services, if there's nothing, if there are no resources in an environment for an adolescent girl who has disclosed violence, then these services are not going to be helpful, and they may place her at greater risk or do greater harm, and providers need to be aware of what resources they can provide and what resources need to be integrated in order to move forward. So getting into the structure of the tool, we have up front the programmatic and service delivery considerations and some planning tools for implementers, and then a removable provider job aid for index testing and partner notification with adolescent girls and young women, which breaks it down into 6 steps. For each step, there is a form and an accompanying script and advice to providers so that they can have those talking points with them and that advice for how to interact with adolescent girls and young women in a youth-friendly way with them as they're going through these forms. As I've said, we've also added a step where we ask providers to go back through and think about the referrals they've made and set a follow-up date for them to follow up with that index client to ensure their ongoing safety, as well as ensure that they have access to the additional services that they've needed. And then finally, because this job aid is not meant to replace the pre-existing tools on HIV services for adolescents, on index testing and on intimate partner violence and sexual and gender-based violence services for adolescents, or on youth-friendly health services, we've included a toolbox with training and guidance resources geared towards providers on those 3 areas. So, with that in mind, we can move into our panel discussion, and I'd like to invite Amelia and Jackie to join us. The first question that we have is going to go to Jackie. So if we can make sure that her mic is working. Jackie, I want to go ahead and start with you and ask you to speak a bit from your perspective as a young woman living with HIV and accessing services, what you think are the key considerations for conducting index testing and partner notification services with adolescent girls and young women.
Hello, can you hear me?
Yes, we can hear you fine.
Yeah, hi everyone, this is Jacqueline speaking. It's really a great honor to be part of this wonderful document that has been created. And I'm just going to speak from a perspective of a young woman or a person living with HIV on what it means accessing services and what are the key considerations. When I looked at the document and as someone who participated in this whole document, the one thing that I loved the most is, there's that consent that is coming in. When we look at the document itself, it's addressing an issue of concept that to me, I still think it's very, very, very good to look up to. So when it goes back to a woman who is in a reproductive age, meaning ready to have babies and all that, this is also another document that is going to address issues around access to services, where we are very sure there's availability, the services are going to be affordable and also flexible for this young woman living with HIV and also planning to be a mother. So it also gives choices, it gives that gap to the young woman to have the decision of saying that I can access services freely without even being asked why I'm accessing the services. because in most cases we find out that if a young woman comes to get services, she's asked why are you taking the service? That question, I'm seeing it being addressed well in this document, and I mean in this program, and I'm happy that, as this program goes on, it will benefit very many people. So I can only end there, but I'm very happy that this came at a time where it's needed. Thank you very much, Chelsea.
Thank you, Jackie. So our next question is going to be for Amelia. Amelia, can you speak a little bit as to why it was important for USAID and PEPFAR to focus specifically on adolescent girls and young women and to develop tools targeting this population?
Sure. Thank you so much, Chelsea, and good afternoon and good morning to everyone. Can you hear me all right?
Could you speak up just a little?
Yes, I will try to speak up just a little bit. Is that better?
Yes. Thank you.
Thank you. So there are two PEPFAR priorities right now that are quite important and that touch upon the topics we've been discussing this morning. The first is, of course, index testing and partner notification, but also HIV prevention for adolescent girls and young women. Now, for PEPFAR, comprehensive index testing services, including multiple partner notification approaches and a strong facility and community collaboration across all sites for all newly diagnosed HIV-positive individuals with immediate linking for treatment initiation is one of the central priorities. In addition, it's also essential to continue to tailor prevention programs for adolescents and young adults under 30, particularly in sub-Saharan Africa. And these prevention activities must be evidence-based for both preventing HIV risk before it occurs and reducing ongoing risks, such as the kinds of programs that we are implementing through the DREAMS partnership. So given PEPFAR's very strong emphasis on these priorities, it's essential that we have tools to meet the unique needs of adolescents and young people. We cannot assume that services that are designed for adults are appropriate or acceptable for adolescents and young people. So for example, as we've been talking a lot about this morning so far, while issues of consent and confidentiality are paramount, the acceptability of services and the quality of the services are equally important. In particular, ensuring that they are youth-friendly so as to reach and retain this population in health services. Furthermore, as has already been discussed a lot this morning, we know that many adolescent girls and young women experience very high rates of violence, and health services play an essential role in a multi-sectoral response to violence. And index testing services is one of those services and one of those sites where experiences of or fears of violence may be disclosed. So as such, we need to ensure that we're able to provide quality, compassionate care that addresses both HIV testing and prevention needs, as well as timely and appropriate responses to violence for adolescent girls and young women.
Amelia. Jackie, we're going to come back to you, and we're going to ask you, why is it so important to consider young women's safety and experience of intimate partner violence when providing HIV testing and services?
Thank you very much, Chelsea. Just like how I said, when we talk about safety, it always has to go back to the woman, I must say. So when we talk about safety in this in this line, the importance is it comes with access to services. When a woman is accessing services, I'll give an example from a perspective of a young woman living with HIV. It's that safety matters a lot to me. I need to get a service when I'm very sure that it's going to work for me. And it's also, it's a service that I'm not going to be getting advice from other people rather than the doctors. So what do I mean is the peer influence is so much at this timing point where you have a lot of choices that are put on your plate, but you have to make one choice. So, I mean, either one or more, or more than one. But the information that is provided, sometimes it's scanty, or it is not so valid for this young woman to make options or to even consider what she wanted to go back with. So in regard to experience of IPFN when providing HIV testing and services, it's not a must that all the time women come into health centers, they receive that services. It's not a must. Actually, in most of the services in Uganda, I would give an example. The services that are provided, so if you have to take like a year to come back for a review after you last had your IPV. So meaning that it gives, we don't know what happens between the time she tested and the time she's coming back for the review. So there should be need to provide updated information to be able to help this woman who has trusted a service and wants to get it in full, rather than getting services in bits. Like she comes today, she's sent to another place. In total, a young woman would so much, not only woman, but each one would need so much to have integrated service. Like if she's coming to receive ARVs, she's gonna receive family planning, and she's also going to receive other health services, that is including IPV. So to me, the consideration comes with the information that has been provided and the integration that we always want to provide to women and even people in general.
Thank you, Jackie. Jackie, I think you've started us on a really excellent discussion for our next question, which is, what should countries be considering as they move towards scale up? And maybe we'll start with you, Amelia. You can respond a little bit to what Jackie's just said.
Sure. I think there are a few essential elements from the perspective of adolescent girls and young women that need to be considered. The first really is the importance, as we've been talking about, of ensuring choice and consent when offering index testing and partner notification services to this population. That really is essential and certainly a part of our approaches to providing youth-friendly health services. And second is to ensure that the consistent high quality of services are available. And this is particularly important when it comes to addressing issues of intimate partner violence, and ensuring that sites are able to provide some type of immediate first-line response and linkage to other services for anyone who discloses violence or fear of violence. Now, I think it's important to note here, to clarify, that when we're talking about first-line support, we're not necessarily talking about that full WHO package of clinical care. But first-line support, thinking about it as almost an emotional first aid, using the WHO acronym of LIVES. So being able that means in this case ensuring that the provider who is offering the HIV index testing and partner notification is really able to effectively listen to a young woman, ask about her concerns and what she needs, validating her fears and experiences, ensuring her safety, and offering her referrals to other services that can help, and this is really essential. And I know there's been a couple of questions coming in on the chat box and some concerns about, well, what if those services are not in fact available? And this is something that we are seeing and encountering often, is that particularly in areas that do not have a whole lot of other comprehensive and multi-sectoral services available, that this is in fact a real issue. And this is something that I think we're going to need to continue to confront and address as we roll out index testing and partner notification, and working with providers to ensure that service providers are trained in how to ask about violence in a way that is respectful and confidential, ensuring that they feel confident in being able to provide that kind of first-line support to adolescent girls and young women, and also taking this opportunity and really working with a range of partners such as Ministry of Health, local government, and other services to try and find ways to enhance post-GBV care services for young women and adolescent girls.
Great, thank you, Amelia. I think I'd actually like to loop some of that question you were referring to from our colleague at FHI about rolling out partner and index testing, partner notification index testing in context where there may not be as many friendly health services or GBV services, into our next question, which is what additional research or investments would you like to see into HIV testing and services for adolescent girls and young women? And I'm going to throw it to Jackie first. And Jackie, if you could also think a little bit about the investments you'd like to see into youth movements and youth advocates and their role in calling for, promoting, and driving forward youth-friendly services and access to youth-friendly services.
Thank you very much once again. So, in regard to what countries should be considering, just like how I said before Amelia came in, I actually talked about the integrated services is what countries should consider. Integration means a lot, especially when it comes to providing to this young adolescent person who is naive and would want to access services, but is not sure of what to take home or what not to take. So the consideration should be around the integration of services. A person comes for an HIV test, tested positive, gets treatment, but at the same time goes back with family planning messages, cancer, and all that information. So considerations should be made around that. Going to the additional research or investments, I would like to see into HIV testing and services. I think we should come up with innovations that, prompt young adolescent girls and young women to come to test, I would say, because a lot of research has been done. I want to be honest. A lot has been done already. I would not say that any additional research. I would rather say, how about we look at the recommendations that have been made in the different researches that has happened globally or even regionally or nationally, and then we look at the recommendations that have been made, and then we are able to know how to change the face of HIV testing for our adolescent girls and young women and services actually. So my additional would be, or investment would be, let's look at the recommendations that have been made in the different either researches or programs or projects. Those would actually really mean a lot to really see how we can change everything for this adolescent girl and a young woman. So that's what I can say. Yeah.
Thanks so much, Jackie. Amelia, same question to you. What additional research or investments would you like to see into HIV testing and services for this age group?
Mm-hmm. Thank you. And I think I would echo a lot of what Jacqueline has already said quite eloquently, as I think there has been some very good research done, not just, formal, randomized controlled trial research, but there's a lot of very good qualitative evaluations and a lot of very important understandings and learnings that we can take from community-based organizations, youth-led organizations, women's organizations in the community about what kinds of services are needed and desired, how should they be structured, how can they be best accessed, and I think there's a lot that can be learned from that and how we go forward when shaping the delivery of services, as well as all of the other associated services that we would want to see around supporting it, such as post-violence care. And so I think looking into some of those sources of community-led research or qualitative research that is available, I think would yield a lot of insights that would be very useful as we look at having to do the scale-up of index testing and partner notification. I think those insights will be particularly helpful to ensure that the services, the testing services being delivered for this population are as sensitive and friendly and nuanced as possible.
Great. So I want to thank Amelia and Jackie very much for their participation in the panel, and I'm not letting them go anywhere because we're going to roll directly into the Q&A. I'm going to ask Anne to join back in to answer some of these questions as well. I'll start with a quick informational question for me, actually, using moderator's privilege. About what's included as part of routine inquiry for IPV in the job aid. And the simple answer is that we've adopted the WHO routine inquiry form from their toolkit for providing IPV and SGPV services for adolescents. We have a simple question about how an adolescent girl, young woman would describe her. So the IPV form is for each individual partner. We have a question about how they would describe their relationship to that partner. We ask if they currently live with that partner. And then we ask 4 basic questions about threat of violence, experience of violence, whether the partner has ever forced that client to do something sexual at a time that they didn't want to, or if it made them uncomfortable, or that they just didn't want to. And if they are afraid for that partner to know their HIV status. And then, again, we've incorporated that decision-making point for providers that if there is a yes to any of those questions, that they discontinue index testing for that partner permanently, and then discontinue index testing for that client until after the client has received first-line support and follow-up services for that experience. So returning to some of your questions, we have a question about how we ensure that the client is the priority and that they are receiving treatment before focusing so much on their partners. So I think maybe, Anne, we can start with you for that, and then Amelia and Jackie, if you'd like to add in, then we'll come back to you after Anne.
Sure. I think that this is a really important question. Obviously, the focus is always on the client. It's sitting in front of you, and I think in this case, adolescent girls and young women. And typically, so I will say that we didn't necessarily get to this point where we're thinking about the ordering of these new services with existing services, but I would think that every provider in every health facility is going to be following the standard protocol in terms of how they go about HIV testing. And I believe that protocol would still be followed, and part of that is once someone is found to be living with HIV, you really move into the support that person needs, them coping with that status, how to get them on treatment. That still remains the priority. I really see the partner notification piece as an additional piece, and the provider would have to decide, is this the appropriate time? Is the person able to have that discussion? Do we need to bring them back in, and maybe when they're coming in for their enrollment in the ART, we then have this discussion? That's why it's really important. I was mentioning earlier that we need to do some sort of, that would be part of the feasibility and acceptability, is how do you actually roll this out? Or it could be part of implementation science. As this is rolled up, what works best in terms of the ordering? But my gut reaction would just be to say that it's most likely going to be following all of the support provided to cope with the status, and also make sure that the client is being cared for and getting onto treatment. So I'm not sure if Amelia might want to jump in as well, but that's just my.
Great. Amelia, did you want to jump in at all?
Sure. I mean, I think Anne's comments are great, and I would just want to emphasize again that for those on the webinar this morning who are PEPFAR implementing partners, I think the message continues to be communicated quite clearly that it is expected that anyone who tests positive is offered the immediate initiation onto HIV treatment. That remains the priority without question, in ensuring that they are linked to that service if it is not offered at the place where index testing is not being conducted. So that there's no question about that. I think, when it comes to conducting partner notification, there are multiple options when it comes to partner notification, and it could be determined at that time that this is not the right moment to do that kind of partner notification service. So I think that that's also an important consideration to note. But really just wanted to underscore the fact that anyone, in this case adolescent girls and young women who test positive, should be offered that immediate initiation onto treatment.
Great. Jackie, if you'd like to add anything to that, you're more than welcome. I also wanted to toss to you, there's a question about support groups for adolescent girls and young women living with HIV and their role in all of this. So maybe you can talk a little bit about how providers can make sure that they are finding those resources and communities for their clients. There you are. We can hear you now.
Yeah. So I just want to respond. I can't. You mean we are still on the one of GBV?
It's a question about support groups for adolescent girls and women living with HIV.
Yeah. Yeah. So.
Go ahead.
Okay, so I briefly saw the question, but I seem not to be seeing it now. Okay, yeah. So someone asked, what's the important when it comes to peer? Is that the one? Or there's another one?
Yeah.
When it comes to support for adolescent girls and young women, are there support groups available? Is that the one we're talking about?
Yes.
Yeah, I want to say that there are support groups at clinic, both clinic and community level. I want to say that, I think the best way to go about this, I am not an advocate for this, but I feel I got so much attached to this, the C3, the community clinic collaboration. It is something that really clearly links the three: the clinic, the community, and the person who is actually receiving the treatment. So I want to say yes, the support groups are there, but maybe what they need is they need to be strengthened to be able to see that they support more of what they are supposed to do. Because at one point, having been one of the peer supporters at a clinic or health center level, I know what it takes, to be a peer supporter. So I think they just need to be strengthened, but yes, they are available. Yeah.
Okay. Thank you, Jackie. And I think Anne has something to add here as well.
Yeah, I just wanted to say, excuse me, on the topic of support groups for adolescent girls living with HIV, ICRW actually just finished a feasibility and acceptability study of such a support group that we tested in Lusaka in Zambia. And so I just wanted to encourage people, it's called the Takambasane intervention. And so I would just encourage people to go and check it out. And we found that it was really quite, they were quite valuable. And the sessions were very much designed with a lot of input from adolescent girls living with HIV and trying to understand what specific topics were of most value to them. And that's how the curriculum was designed in a very participatory manner. And so, you know, for example, sessions would there would be a session about, you know, what is ART and all of that, but it went much further beyond that, dealing with issues of stigma and violence and disclosure, and taking it much further than the typical support groups, the adherent support groups that are run out of healthcare facilities. So we found it to be a really useful and acceptable intervention, and I think there was a lot of interest from health facilities there at sort of picking up the curriculum. So the curriculum is there to be downloaded and used, and I just wanted to, maybe we can send it through the chat box for people. I just wanted to highlight that.
Yeah, and we can also send it out with the webinar and the additional resources. I want to get to Joya's question, which I think is super important in this context, which is, we know that in many of these situations, providers are dealing with an incredibly high volume of clients, and they only have a few minutes to offer each client counseling. So how do we advocate for, create space for providers to take the time that's necessary to counsel and safety plan with adolescent girls and young women, and work with facility managers to make sure that they're supported to do so? And maybe we'll start with Amelia for this one, if that's okay.
Mike, here.
Amelia, I think there you are.
Okay, sorry, there we go. Yeah, it's a great question, and there's always this sort of tension between the sites with very high volumes of clients coming through and the need to spend time to do this in a way that is both effective and meaningful. So I think part of the challenge to us as the index testing and partner notification gets rolled out is to say that this step of ensuring that that index cases are safe and that we are able to ask about violence in a way that is adherent with WHO guidelines is an essential part of doing this work around index testing. It's not something that's necessarily, you know, it's not a nice add-on to do if you have time, but it really is an essential step in ensuring the quality of services. And so I think as we move through this process of rolling out these services, being able to ensure that providers feel comfortable to ask the questions in a relatively seamless way as a part of this process, I think will be important. There was a study that was done several years ago by the Population Council that looked at the feasibility and acceptability of integrating violence screening questions into HIV testing, and this was within a hospital setting. And the results of the study, led by Nicole Haberland, were quite good and quite interesting, and it showed that the additional time to ask these questions, I think it added a couple of minutes onto the overall process of HIV testing in that facility, but they found that it was both feasible and acceptable both to providers as well as to clients. And so I think that there is evidence to show that this is feasible, and I think what's important is that we continue to articulate that this is not something that is you know, an optional part, but it is an essential component of quality HIV index testing and partner notification services to ensure that everyone who is part of this process feels safe, feels validated, and that we are following their wishes. Again, getting back to that piece around choice and consent.
Great. And I also just want to speak a little bit to the job aid that we've developed, and one of the reasons why we've incorporated adolescent-friendly scripts alongside each of the forms for providers to go through is so that they have that resource in hand as they're going through each service. I think, you know, as a service designer, We're frequently confronted with this challenge between quality of care and time available for care. And so we really designed this tool with the provider in mind and with the help of clinical advice to make sure that providers have everything they need right in front of them when they're using it, including asking for the facility manager when they're planning these services to do a bit of a mapping of other available services in their area so that those referrals can be made quickly and easily and then followed up on accordingly. Did anyone else, Jackie or Anne, want to jump in on the question of time available and how to create time for this type of service? Jackie, maybe starting with you.
Okay. Is this the question from Joya?
From Joya, Jackie. It's okay to say no if I'm putting you on the spot.
No. I was just checking it out because I had really, but I think let me have maybe Amelia respond and I can add
Amelia, again, just one other thought on this issue of the time question. I think it's my sense that a lot of service providers very much want to do the right thing and they want to be able to do this kind of service well. But there is, it's not easy asking about experiences of violence or figuring out how to do this in a way that is most helpful. And so I do think that having some additional time to train providers, not just in raising awareness of the issue, but helping to develop the comfort level and the familiarity with asking the questions and then knowing what to do when someone responds is really important. And I think as that comfort, and if you can call it comfort in asking about violence, but that familiarity in asking about it as part of a routine process of doing the HIV index testing, it will hopefully help to ensure that the services do flow more smoothly. But again, in some of the research that we've seen, service providers, they do want to be able to do this well, but oftentimes they cite sort of a lack of experience or a lack of confidence or just not knowing what to do in some cases. So I think as we think again about the scaling up of index testing and partner notification services, is having that piece there of training with the service providers to ensure that everyone has that level of comfort and familiarity, and that they know what to do when someone responds one way or another. That also becomes very clear for them as well. I think that would be particularly helpful.
Right.
Oh, and just to add to what Amelia just said, I completely agree about the training component. We, ICRW worked with WRHI to look at a study. We were doing a feasibility and acceptability study. It was called the EMPOWER study with young women, and it was in the context of PrEP uptake and adherence. And part of that process was integrating GBV screening into HIV counseling and testing. And it actually worked really well, and we have a paper coming out about it, and it was presented at IIS last summer. But I just wanted to say that one of the things that we found that was extremely useful was the training. We had to have a lot of training with the counselors to basically build out their skills to be able to counsel on both things, but it really didn't add too much time to that first session with the young women. So I think it's definitely feasible. I completely understand that sometimes clinics are really jam-packed with folks, but strategies such as having a few adolescent youth-friendly days, those kinds of things might help to streamline and make sure that you have trained professionals who on those days are really keyed up to be able to provide this sort of expanded service with the screening as well as the HIV testing. I think could be helpful.
Okay. I think that actually rolls us into, there's another really excellent question around how these services overlap with the use of community counters, with community health workers and voluntary health workers. and if we know anything about how partner notification services operate sort of outside the health center. So, Anne, I'm going to put you back on the spot real quick.
Well, I can speak from a long time ago in Uganda. I was part of the sort of initial development of the home-based testing sort of movement. And I know that from that, we definitely worked with lay counselors who were trained to go out and do the home-based counseling and testing. And that definitely worked really well. And I think when you have the whole family unit together, that was really helpful. Now, I don't know in the context, that wasn't something, because typically it was a family and you had the married couple together, you could definitely pull people aside, and there was a whole protocol to follow for anyone who was positive, were getting them the services they needed. But I could see that you could, in that model, add on a piece about partner notification, and you could add in a piece about a screening piece. So I feel like that is something that could potentially, I'm sure there are many people on the phone who are implementing these services more recently than I was involved in them, who might be able to chime in there. But I do think that could definitely work. I know that there's a big push through studies like PEPFAR, where they're utilizing a massive amount of community healthcare workers to go out and really go door to door. And this is related to the immediate initiation of ART, but I think also it would be easy enough to add in these extra components, specifically with adolescents. I think a lot of the services right now, those services, that home-based services, aren't necessarily geared towards adolescents, and I think that's something that we could probably easily shift along with these types of tools.
Jackie, I wonder if you want to come back in to talk about whether community-based services and home-based services are more accessible for adolescent girls and young women, and what we can do to be supporting those services to be more youth-friendly.
Thank you very much. I want to say that the access, I think I'm seeing a lot of messages, but when it comes to the community health services, okay, there are community based services, I would say, because when you look at the adolescent girls and young women who come from the key population component, of course, countries or even programs have set, have set programs for them. For example, when you look at the group of sex workers, there's been what is called a Moonlight program that has been set for them, meaning they can always access services at the time of their convenience, meaning that the face of access to services for everyone is changing. However, it comes with challenges. For example, however much some of these services are accessed, some, there's still that stigma or even denial to access these services by the people who are supposed to take the services themselves, because they still feel that, how would I go and access these services? I mean, this service in a place where everyone will see me. So there's that component of the stigma that I would want to bring in, that is both self and then stigma by others. So it is something that I see as a potential threat, I would say, at the moment, but I would say it is something that is there. Services are there, community-wise, and also regional-wise, or even nationally. So I can only say that as my own understanding, but maybe Emilia would add on something, and also other members can add on.
Hi, this is Amelia. I just wanted to make a note that as we think about the index testing priority, PEPFAR's index testing priority, in that we need to be careful that the focus stays on index testing and not on the broader community-based approaches to testing that we have done in the past. There's been a strong focus on trying to keep the testing as focused as possible, really on this this case-finding approach, and less on the broader, these broader community approaches. So I think the venues where index testing could be done are certainly important to consider, and where we want to be reaching people. But we want to be careful that just because we're doing sort of testing in a community setting, that we're not all of a sudden, broadening that out perhaps to every single person in the community, and as such we're doing a whole lot of over-testing. But again, keeping that focus on that index testing modality. So just wanted to note that.
Great. Thanks, Amelia, and thank you, Jackie. And I think it's also important to note that when we say that this is a tool for providers, we are talking about providers of all levels, not just within health service centers. So hopefully there will be, I think it's important whenever we're talking about rolling out services that we think about who's providing services, who has access where, and the need to make sure that as we're improving services, making them of higher quality, more accessible, more youth-friendly, that needs to run through every cadre. So hopefully this tool will not just be useful for health centers, but also for providers going out into the community and help improve those linkages. So we've got a few more minutes left for our Q&A. We've got a question about recommendations for monitoring and evaluating these services, and then a great question about our rollout plan for this tool. So we will come to the rollout plan for this tool at the end, just a little preview for you. But before I go to our panel about the monitoring and evaluation, I also want to highlight again that one of the things that we've added to this job aid is we've asked providers to set a date for follow-up with the index client for themselves, to make sure that after partner notification services are performed, that they are checking back in with that index client to ensure that she is still safe, still accessing treatment, still connected. And we've also added a checklist for them to track every referral that they've made to her and make sure that they have a follow-up plan to help her see that through, which is not quite monitoring and evaluation, but I think it's very, very important to flag. So for the monitoring and evaluation question, I think perhaps we will start with Amelia, and then if Anne or Jackie have anything they want to come in with, you're more than welcome to.
Sure, thanks. So I think some of the points that you just raised about what's included in the tool are really important and will be helpful as part of a monitoring and evaluation, monitoring process. Pardon me. For PEPFAR implementing partners who are implementing HIV testing, there is, of course, the required MER indicators that need to be that where there are targets that are set and results that will need to be reported upon. I think those are very that's obviously essential and needs to be done. I think also being able to show those linkages, like the number of individuals who test positive and who are then linked to and immediately initiated on treatment, will also be really important to show. Though that linkage is oftentimes hard to document, but I think that's also going to be an important piece of this. I think throughout the presentation there was also some strategies about the monitoring the overall service quality and having feedback from clients themselves about the acceptability of the service, particularly from the perspective of adolescent girls and young women, and getting feedback on whether or not these services are youth friendly. Would they encourage their friends or their peers to come to these kinds of services? I think that will also be very important. In the past, we've had some conversations about, well, how do we monitor outcomes related to violence? And that is admittedly a little bit more difficult because it's not necessarily possible to attribute, to do a direct attribution of, if someone discloses and their partner is violent, well, if their partner is always violent, or is frequently violent, It could be any number of things that could set off a violent partner. And so being able to trace it back to that specific partner notification, it might be challenging to do that, and we might not be able to get the most reliable data on it. But I think there could be other ways of monitoring for those kinds of adverse events related to partner notification. I think it will be important, particularly as services scale up and expand. We want to ensure that we're doing so with quality, and not just quality to the testing piece, but also to that intimate partner violence piece as well. So the ability to be able to track and monitor for those kinds of adverse outcomes, to monitor the quality of services, to ensuring that those linkages between the index testing site and other perhaps non-clinical services are functioning will continue to be an important piece of that program monitoring.
Great, thank you, Amelia. So I think that probably sums it up pretty well. I do want to note for the question about how we plan on rolling out these tools, they will be available in the very near future. We will be sending out a link with the recording to this webinar to a page where all those resources will live, and letting you know when those resources are up. Hoping in the very near future, I think is what I'm allowed to say here. So I'm going to ask Anne to come in and summarize a little bit of what we've heard during the Q&A, and then I'll come back in with some advice for you on how to stay connected to us.
Sure. So I think firstly, thank you everyone. These were great questions. I thank the panelists and thank the people who shared questions with us. I think you're really getting at the heart of this. We recognize this is important. We recognize this is going to be a focus, a big emphasis in the coming, I know, COP cycle and everything. And people really want to understand, how do we do this? What's the best way to implement? What's the best way to monitor? And I think these are really the questions that are most important. We want to make sure that we are keeping adolescent girls and young women safe, yet bringing them into services in a supportive manner. So I think that we're all on the same page with that, in that regard. And I hope that the conversation continues forward. I think as each implementing partners in different countries begin to roll this out, I hope that we can continue to have these discussions where we're learning from one another about what's maybe happening in Cote d'Ivoire and what's happening in Malawi, and how we can make sure that we're really coming up with the best approach to implement these services so that they're both effective and safe for adolescent girls and young women. And I'm guessing through YouthPower we might have the opportunity to continue to have these types of conversations. So I just want to thank you all for your participation and turn it back over to Chelsea.
Great. Thanks so much, Anne, and I want to echo Anne's thanks to our panelists, Amelia Peltz and Jacqueline Alisi. It's been really wonderful working with both of you and having you online and answering some questions today. So a little bit about how you can work with YouthPower Learning going forward if you're interested. We have a lot of different activities that are all accessible and available through our Learning Hub, which is youthpower.org, where we share resources, our own and others. If you have resources you'd like to contribute, please go ahead and let us know. Events, information, and the latest that we know about what works, including new indicators, new ways of following up, new ways of understanding what positive youth development means and how it is operationalized in the field. We have a positive youth development learning agenda that we're focused on, trying to really narrow in on some of the gaps in what we know and what we don't know and answer some questions that are out there. We also have 4 communities of practice. I, of course, have a particular pitch for you to join our gender and positive youth development community of practice. But there are also communities of practice on youth engagement, youth and peace and security, and cross-sectoral skills for youth, which are also excellent and have excellent co-champions as well. And just again, thank you. We do have a website up on your screen. This is where all of the resources discussed today will be posted. We will also have the recording of today's event, which we will share with you. If you put a question in the chat box that we did not get to, we will try to get back to you individually and also include any responses in our follow-up to the webinar to all participants. If you have additional questions for me or for any of our panelists, we'll keep the chat box open for a few minutes. You can add them in, or feel free to email us at YouthPower or join one of the community practices and start a discussion there. Thanks again for joining us, and have a lovely day.